Excuse me, ladies and gentlemen, thank you for your patience in holding. We now have your presenters in conference. Please be aware that each of your line is in a listen-only mode. You may submit your questions electronically anytime using the Q&A pod located to the left-hand side of your webinar platform. You may also download a copy of the presentation using the resource pod located directly below the Q&A pod. It is now my pleasure to introduce today's first presenter, AHA moderator Monique Showalter.
Thank you so much, Katie, and welcome everyone. This is Monique Showalter with the American Hospital Association. All of us here at AHA hope each of you are safe and well, and thank each of your organizations for your outstanding care and dedication to the patients of your communities. The American Hospital Association is pleased to be hosting today's webinar entitled Using AI and Automation to Drive Action, from command centers to the front line. This webinar is brought to you through the generous support of Qventus. As health systems face pressure to integrate healthcare delivery and drive operational efficiency system-wide, many leaders are pursuing command center strategies. But too often, these projects are unsuccessful due to EHR limitations and a high reliance on manual efforts. In today's webinar, we'll hear how St. Luke's Health System has taken a new cutting-edge approach using AI to automatically predict issues and orchestrate resolutions from the command center to the front line. By augmenting their EHR with new predictive capabilities, St. Luke's has streamlined care progression, processes, improved load balancing of capacity, and optimized post-acute placement across the system. As a result, they've eliminated thousands of excess hospital stays and created a significant amount of new bed capacity. During today's webinar, we'll hear how to complement your EHR with AI, machine learning, and behavioral science, how you can decrease excess days by 50 to 90% using real-time automation, how you can reduce manual burden and support your frontline teams, how to hardwire and connect care processes at the patient, facility, and system level, and how to optimize throughput across your system. Note, too, that we've allowed time for your questions. We've already received several, which our speakers will address as time allows. Note, too, that if you wish to download the presentation, you can easily do so through the resource section of your screen at any time during the presentation. Also, the event is being recorded, and the replay link will be sent to all registrants and attendees shortly after today's event. So with that, let me briefly introduce today's outstanding speakers. Debbie Gash is the Senior VP and Chief Digital Officer for St. Luke's Health System in Kansas City, Missouri, leading a broad range of digital initiatives and solutions across the health system, including developing and augmenting IT strategies and fostering a digital culture. Debbie is responsible for updating the necessary standards, infrastructure, and security policies to protect the system's information assets and also ensure quality IT support for the health system, providing guidance in cost-effective clinical and business solutions. Debbie began her career in healthcare managing physician offices and patient accounting, and as a healthcare consultant, having joined St. Luke's Health System in 1992. Debbie is a graduate of the University of Missouri with a bachelor's degree in health services management and a master's degree in business administration. Next, I'd like to welcome Dr. Anthony Fangman, the Division Chair of Hospital Medicine for Metropolitan and Regional Programs for St. Luke's Health System. A board-certified internist and a full-time hospitalist since 2002, Dr. Fangman serves not only as the Division Chair of Hospital Medicine, but also as Medical Director for the Hospitalist Group and the Chair of the Clinical Innovation Committee. Dr. Fangman earned his doctorate in medicine from the University of Kansas Master's in Business Administration from Benedictine University, and Bachelor's of Chemical Engineering from Kansas State University. Finally, I'd like to welcome Dr. Mudit Garg, the CEO and co-founder of Cuventus. The Cuventus platform uses machine learning and behavioral science to automate patient flow and transform operations for leading health systems across the country. Prior to Cuventus, Mudit co-founded multiple technology companies and also served with McKinsey & Company's healthcare practice, helping large provider organizations with organizational transformation and performance improvement. Mudit earned his master's in business administration and electrical engineering from Stanford University and a bachelor's degree from the Indian Institute of Technology. It's now my pleasure to turn the floor over to Mudit to begin today's presentation with a review of the agenda. Mudit, the podium is yours.
Thank you very much, Monique, and it's a pleasure to have so many of you here with us today. Before we begin, I'd first like to thank Debbie Gash and Dr. Fangman for leading the session today with me. As you'll hear from them, St. Luke's has been an amazing partner, but has most importantly developed a cutting-edge digital health strategy to help advance the health system's mission, and AI and automation capabilities forming a critical foundation for that strategy. We had the honor of starting to work with them actually right at the beginning of the pandemic when they saw the need to accelerate this work, and we've been very grateful to have the opportunity to do various different innovations together over the past 2 years. So excited to share the story of our partnership together, and we have an exciting agenda lined up for you today. So first, we'll hear about St. Luke's vision and strategy for operational efficiency across the system. Next, we'll talk a little bit about how automating care operations helps address these challenges. And then we'll segue for the bulk of this session around driving action and how St. Luke's is using AI and automation to drive action from Frontline and in the command center. And we intend to save about 10 minutes at the end for Q&A from anyone else. And that's the plan for the day today. So without much further ado, I would like to turn it over to Debbie. Debbie, thanks for joining, and thanks for sharing St. Luke's vision and strategy.
Thanks, Mudit. As noted here, St. Luke's is an integrated delivery network in Kansas City. We started our throughput improvement efforts in 2016 with the launch of central patient logistics. It's a co-location of central staffing, patient placement, our transfer team, and other personnel at our flagship hospital, St. Luke's Hospital of Kansas City. Our initial vision was to ensure we place the right patient in the right hospital with the right patient status in the right bed with the right nursing staff. Since then, our system has grown both geographically and through our service offerings, further increasing the reliance on central patient logistics. Destination 25 is our North Star strategy for the system and is designed to help our system evolve to address increases in demand for patient care, increasing acuity, and a need to be strategic about how we handle and steer different patients in our different settings and staffing challenges that we're all addressing in the industry today. Our strategy is comprised of 3 pillars, which is to improve access, accelerate digital adoption, and deliver value. The new strategy highlights the importance of throughput. We needed to evolve to a system where we could manage care progression across these settings in order to optimize our system resources and teams. So with this foundation, we have then aligned on a methodology that would advance our strategy for throughput. Our methodology encompasses the full patient care continuum, and it reinforces itself, meaning that if we can unlock efficiency for one patient, it creates downstream capacity and improves access for the next patient in the door. At the highest level, we want to align resources to manage length of stay, by placing patients at the right access point with the right resources and the right follow-up care. So to do that, we first needed to get patients to the best access point for care. We then needed to align the right resources to deliver the care and do so in an efficient manner. And finally, we needed to optimize post-acute placement and follow-up care. We aligned metrics with each of these areas that will ultimately help reduce length of stay and maximize the efficiency of our system. In order to manage all of this in an efficient way, we first had to understand if we had the right capabilities in place. Over the past few years, we have heavily invested time and resources to maximize our EMR functionality and how our teams are using the system. We first explored how to further maximize this system, but realized there were limitations. We first had a patient flow assessment report that our EMR vendor completed, and we implemented those initial recommendations, such as adding their transfer module, their logistics module, but they weren't predictive, and we were still managing retrospectively. We also tried leveraging the EMR throughput dashboards, but the problem was that they only considered geometric length of stay and didn't look at patient-specific considerations. We used some of the barrier checklists and discharge milestones, but these required manual updates, and teams didn't necessarily see the value since they were only a checklist. From there, I started to do some research on command center concepts, and my high-level takeaway was that they only replicated what the EHR was doing for us. So we reached our limit with those existing systems, and we needed new enterprise capabilities. First, these capabilities had to integrate with the EHR and leverage real-time patient data. They needed to drive action across our system and reduce the cognitive load and also drive automated workflows. And they needed to help our physicians and our care teams. Taking a step back, we needed these new capabilities to catalyze change for our organization to move towards a more digital health system. We needed an enterprise forcing function. So this is what led us to seek new predictive capabilities, which I'm going to hand over to Moda to share with you what those are.
Thank you very much, Debbie, for that overview. I think the challenges that you outlined are similar to what we hear from many leading health systems across the country, and as you shared, the predictive capabilities around automating care operations, we hear from many being the next frontier for health systems. So let me maybe start by introducing Qventus and what motivated me and us to start working on this problem. I started the company after years of working in performance improvement at health systems nationally, and from the very get-go for me, I could see across health systems that I worked with that we had world-class clinicians, world-class equipment, and therapy available, but everything that surrounded that core delivery of care felt like was behind the times. And it ended up implying that those world-class clinicians, staff, equipment, therapies weren't being utilized to their full potential, and it required heroics and cheerleading from them every day. So the question we asked ourselves was, what can we do to simplify the logistics that surround the delivery of care? And that's what we would call care operations, areas that are immediately adjacent to the delivery of care, access, throughput, care coordination, as Debbie was referring to them as well. We built a platform that combines AI, machine learning, and behavior science, along with expertise in clinical operations, performance improvement, and change management, to build a platform that helps automate these areas of care operations. We are fortunate today to do that with 120 plus deployments across the country, like St. Luke's, ranging from complex academics to community hospitals and safety net institutions, and are able to see excellent results by focusing on improving these areas of care operations. Taking a step back for a second, I think the impact of inefficient care operations actually is a huge pain point, and their impact is very clear and significant. So just a couple of examples from external research. One, the advisory board sort of has shared data around the fact that 22% of hospital days are excess days. So especially at a time like right now, where staffing is so challenging, to be able to have capacity locked up in time that the patient didn't need to spend in the hospital almost feels criminal. Similarly, waste in terms of the operating room, where you hear from surgeons and patients that they often can't find space in the OR schedule, while at the same time the OR is 70% utilized. Or in the ED, where a quarter of the time the patient's spending is in some process step waiting to be seen by the physician. So these problems of inefficient care operations affect us, affect the patients, affect our ability to serve the patient on a consistent, regular basis. And the specific reason is, if you especially look at the environment right now, improving care operations creates significant value, especially in today's environment. I think I don't need to tell all of you since you're intimately familiar with it, but we are under tremendous pressure in a perfect storm of sorts today. We have declining reimbursements, high costs and affordability challenges, staff that is burnt out, and a high degree of variability site to site. And the beauty of care operations improvement is it very directly addresses those challenges that come to be today. It allows us to increase revenue by being able to free up inefficiencies and serve more patients in the resources that we have today. It allows us to decrease costs, for example, be able to break even on Medicare patients, align staffing with demand, while at the same time being able to achieve systemness, i.e. standardization across the variability that exists across units and facilities, and most importantly, doing that in a way that doesn't ask our staff to do more heroics and more cheerleading and more diving catches, but actually enhances their well-being along the way. So that's sort of the reason we hear a lot of interest across the board in how do we improve these areas of care operations, much like Debbie was laying out. The challenge we see, though, is historical efforts of improving areas of care operations have often been manual in their nature, i.e. we have either done process improvement alone or asked teams to do more things alone, and that doesn't scale because that very much relies on manual efforts from our frontline teams and from our frontline managers in an environment where they're already overworked and tired. Frontline managers manually sifting through information, manually assessing what decisions need to be made, making those decisions, and then following up and tracking when things are happening or not happening leads to both lack of those improvements, but also a wide degree of variability. So that's the context which sort of brought us to the desire to automate as much as possible in this area of care operations. So to take a step back, if you think of the various opportunities of automation in healthcare, there are opportunities of automation that are around tasks, let's say around payroll processing or timesheets, tasks that are being done by people right now that are pretty low variability and fairly straightforward, and you can perhaps automate those tasks and don't need a human to do those tasks anyways. That's one kind of category of automation. Another kind of category of automation is you might be reading an image or detecting cancer from a screen, and the machine's being able to do that. Lots of value, high downside and high risk in those decisions as well, and the role is of mostly human-led but machine augmentation. But this space in the middle requires a unique set of capabilities, the space around care operations being automated. These are areas, as I was sharing, are areas that are adjacent to delivery of care. And what's unique about it is it's pretty important that while you're not making clinical decisions, while the decisions you're making are operational, that what informs that operational decision is an understanding of the clinical data of the condition of the patient. Because how the patient is progressing allows you to best understand how to staff. It allows you to best understand how to coordinate and prioritize the barriers that stand in their way. And the second key characteristic of the platforms that are needed in the space is you have to recognize that there are different degrees of human-in-the-loop automations that need to be driven in this, i.e. you need to be able to augment teams, in some cases nudge teams, in some cases support their decision-making, and that's very critical in what's required in the space. And we've built the platform specifically to be able to be very adept at supporting these care operations needs. So we built this platform combining a set of key capabilities. Of course, we take the data from your existing systems of record, like Debbie was mentioning, your different EMR systems and other systems of record. But then we really think about what would allow to form an organizational habit. So the platform's capabilities allow in any process us to identify issues, orchestrate actions, and manage the accountability. Very much the steps that are required to be done manually to create improvement today, but how do we create automation around those steps? And we built a very flexible platform to be able to apply that to many, many different areas of care operations. But we recognized that just that automation wasn't enough. So while we built a platform that was flexible, on top of the platform, we built a set of very prescriptive best practice solutions. And this is where we specifically study high pain point areas for our health system partners, understand what are the key important points of leverage which need to be automated, and then apply both automation, best practices, and change management to create a holistic way of delivering that result and that ROI to our partners. And I think that's very, very critical as well, in that it's very important to have the underlying platform capability and for it to be flexible, but that by itself is not sufficient. We need to drive the complete change for that to be valuable and for it to work well. So we've seen, as we've done that, significant impact across health system partners in both reducing access days, improving surgical demand, creating 3-bed capacity, and I think that combination of the technology and the pre-baked solutions is what gives us high confidence in driving these results day in and day out. So with that sort of context, I'd love to hand it back to Debbie to share a bit more about St. Luke's specific results and specific actions that they've taken themselves.
Thanks, Mudit. So with that background on automating care operations and predictive capabilities, let me tell you about our vision of automating our operations. So we're in the process of deploying real-time operations in many areas across our system, but we actually first started working with Qventus using their COVID-19 planning tools. We then decided to expand our partnership with Qventus and transform our operations from an enterprise-wide perspective. We're deploying the inpatient solution at 2 of our highest capacity, highest demand facilities to improve throughput. We're also deploying the perioperative solution at one of our key facilities, and we're launching the Qventus Command Center solution, which helps us drive efficiencies across the system, as I described before. I'm going to turn it over to Tony Fangman to tell you about our inpatient throughput work at this point.
Thanks, Debbie. I'd like to talk about how we're automating discharge planning to improve patient throughput. As Debbie mentioned earlier, optimizing throughput is the foundation to unlocking greater efficiencies across the system. In the past, our teams were managing discharge planning through the EHR, bedside conversations, calls, and discharge meetings. On admission, the discharge plan is formed without a consistent process across the system. Over the next couple of days, the patient's discharge date and barriers were identified, but there wasn't a solid and efficient way to communicate with the various teams. There are many moving pieces. I'm sure this is no information that everybody else does not have already. One particularly difficult barrier is coordinating post-acute care needs. In addition, leaders were handicapped without real-time data to focus resources when needed. These inconsistencies across the units led to focus on current day's discharge, the work faster and harder mentality, which leads to burnout. As we think about this problem, I refer back to my engineering days and the theory of constraints, a methodology for identifying the most important limiting factors or barriers to an outcome, attacking those barriers, and prioritizing workflow to achieve the goal, improving throughput. In the case of hospitalized patients, the barriers include things like physical therapy, skilled nursing placement, MRI completion, and others depending on the location and diagnosis of the patient. The complexity and vast number of potential barriers in the inpatient care process makes it difficult to navigate. Simply put, it takes a lot of communication and coordination only to turn around and do it again the next day. For all of these reasons, we chose to standardize and reduce friction in the inpatient throughput with Qventus. It utilizes the constraint theory of throughput with some machine learning to have continuous process improvement. One of the first things that we've seen is a shift to discharge planning upstream. By earlier prediction of the discharge date and barriers, the discharge planning is shifted upstream with communication to ancillary services and teams. The process is standardized with a focus on future discharges. Qventus models learn by analyzing thousands of data points to make predictions specific to each patient. Early in the setup and continuously, the clinicians and care teams input barriers and predicted discharge dates. This teaches the AI-driven software to predict future patients' barriers and their discharge dates. This intelligence reduces care team workload by establishing and updating the discharge plans continuously. 45% of discharge dates are auto-populated within the system by Qventus. Specifically, it auto-populates or recommends a date of discharge, disposition, and barriers to discharge. The intelligence automatically updates throughout the care journey, so it's easier for our teams to make sure the discharge plan is accurate and up to date. Key information is then written back to the EHR, which reduces documentation burden as well as duplication of communication. The care teams on a daily basis use Qventus Pathfinder to drive multidisciplinary rounds for discharge planning. This provides a visualization tool for the rounds. The AI-driven platform automatically tees up which barriers are the greatest rate-limiting step to that care team's patient to focus on at that time. So overall, this enables more accurate discharge dates early in the stay, early identification and communication of barriers, dispositions identified early in the stay, and it hardwires the process to reduce burden on frontline care teams. Next, I'll talk about some of the barriers and how they're addressed in real time and the accountability piece. With the discharge plan and barriers captured, Qventus prioritizes the work list of our ancillary teams utilizing the priority queues platform discharge. It's an example of where behavioral science is embedded in the technology. So instead of a first in, first out work list, which our teams used in the past, Qventus helps prioritize the workload to focus on earlier discharges. Currently, we have 10 ancillary orchestrations at St. Luke's East Hospital and 11 ancillary service orchestrations, as well as 2 dialysis unit work lists at our tertiary care center. These are things like physical therapy, etc. Qventus also identifies potential missed barriers earlier in the hospital stay to prevent them from becoming barriers. An example of this is that it sends a patient list to our hospitalist or physician care team predicting who needs a physical therapy consult and does not have that. This assures that the services are ordered early in the stay to avoid post-acute care setup delays. Next is the leadership management accountability piece. Qventus helps detect and escalate when something is deviating from the discharge plan. An example is, as Mudit said, a nudge to the local leaders when a patient is identified as out of the discharge plan. So, for example, a discharge before noon patient and they're still in a bed, it gives a nudge to enable the leadership to be more proactive in real time to help resolve those issues. Leadership also gets detailed dashboards to focus on continuous process improvement across the system. Reports include things including length of stay, top barriers, estimated data discharge accuracy, as well as others. These can be drilled down to the unit-specific level. Next, I'll discuss the impact that we've seen to date. So, by shifting planning upstream and attacking the barriers, we've seen a significant decrease in excess days and length of stay. with early discharge plans, meaning that discharge date is predicted and disposition are predicted before the second midnight stay. In this graph, you can see that at St. Luke's East Hospital, there's a decreased average length of stay of 0.6 days for those with an early discharge plan. And the Hospital 2, St. Luke's Hospital, there's a decrease in 0.3 day length of stay. So some significant decreases early on in the implementation. Next is the benefits to physicians and care teams. The next benefit is really to the physician and care teams. There is a greater predictability around plans and discharge planning, which results in fewer interruptions and reduces the stress on the care teams. We specifically measured our secure text messaging, and in looking at our hospitalist to RN inbound and outbound text communications, we observed that there have been 16% fewer messages in the 7 months since go live compared to the 7 months prior to go live. And this is in light of the COVID surge that we saw in Missouri. Finally, this process allows teams to focus more on the complex acute patients, thus utilizing their highest skill set. And with that, I'll turn it back over to Debbie to discuss the perioperative access and growth.
Thanks, Tony. At the facility level, in addition to hardwiring discharge planning, we've used the Qventus predictive capabilities to increase our perioperative access and growth. So here at St. Luke's, we face similar challenges to what I'm sure many of you are likely experiencing with perioperative services. First, we needed to accommodate growing demand for care. We needed to be able to do more with less. And like many of you, we've experienced a very challenging environment due to COVID with a backlog of cases and staffing shortages. We couldn't let these current challenges slow us down, so it's been more important than ever to optimize how we are using our resources and our staffing. Finally, we needed to strengthen our margins. In the past, we've tried various approaches to address the challenges in the operative workflow, such as improving our policies and the use of our EHR, but we definitely needed a new approach. So we were really intrigued with the Qventus product when it was brought to our attention. I'm going to give you an overview of the 3 modules that our teams are currently using. The first 2 modules, Access and Growth, are designed to work in tandem with reinforcement from the Insights module. First, the Access module uses AI and machine learning to automate the process of unlocking as much open time as possible on the OR schedule with your existing block framework. The machine learning surfaces blocks that are unlikely to be used, and then it applies principles of behavioral science to incentivize the release of that time. Next, the Growth module uses machine learning to identify and offer time to the best fit surgeon. It reduces the difficulty of the game of Tetris or our OR schedules have to play on a daily basis. Finally, the actionable analytics not only put the important metrics at your fingertips in real time, but they give you the data to enable productive conversations with the surgeons. So as I mentioned earlier, one of our goals was improving our release block time and overall utilization of our ORs. Through the Qventus system, we've unlocked over 170 hours so far, and this is increasing each month as we drive adoption and use of the system. Our utilization is also strong, with 37% of release block time being utilized. This translates to over 64 hours of release block time from the system alone. Since deployment, we've really seen an acceleration of cases that are flowing through the Qventus system. In just the last month alone, we've seen 109 cases come through the system as engagement has increased all across all of our surgical stakeholders. This is already driving a great return, and we anticipate that the impact will only increase in the months to come. I've described, and Tony, how we have the two ways that we're using the predictive capabilities at a facility level in our inpatient and perioperative settings. As described in the beginning, our vision is to use these predictive capabilities across our enterprise. So with that foundation in place, our next area of focus is using predictive capabilities at the system level in our command center or central patient logistics center. When we first explored different command center strategies, we found that most only replicated the EHR capabilities. It plays out in a few ways in these traditional command centers. Teams are still reactive because the only visibility they have is into the admit at the day of discharge. These systems level teams are navigating through walls of dashboards, so it's challenging to find the right issue to focus on. And the command centers are often disconnected from the highly variable processes across all the facilities, so it's incredibly difficult to drive outcomes. We believe that with automation and AI predictive capabilities, we can have a much more effective approach. First, we're maximizing throughput by optimizing the full acute patient stay. The inpatient solution hardwires best practices starting from day one of the stay, not just the last 24 to 48 hours to discharge. Second, it can reduce the noise by surfacing actionable opportunities to the appropriate stakeholders and reduce the cognitive burden on the staff. The AI automates routine decisions and pushes specific issues to the care team, facility leadership, and the command center staff to resolve. And third, we've standardized best practices across the facilities, a process foundation, which gives us more complete situational awareness and optimized operations across the enterprise. One of the biggest differences in this approach is how we handle bottlenecks, either real-time or predicted ones at different altitudes. By automatically surfacing these opportunities to the appropriate stakeholders at different levels of the organization, we can optimize the way they are resolved. We're reducing the noise, and the command center staff don't need to comb through dashboards or triage all the alerts that get blindly escalated to them. In fact, when issues arise, we believe that 80% of them can be managed at the facility level and only 20% need to be addressed at the command center level. As I described previously, we've established our central patient logistics a few years ago and co-located resources and teams. This comprises a number of core functions of the St. Luke's Health System. The new predictive intelligence, our patient flow operations center, is a new layer that enables us to optimize many of these functions in new ways. First, we're developing system-wide capacity intelligence that will underpin our future use cases. Here, we're focused on creating situational awareness across the enterprise and proactively managing bottlenecks and surges before they occur. Today, leaders are often reactively fighting capacity crisis because they have limited visibility into the demand. By the time the units are full, folks are scrambling to figure out who can be discharged or where discharge can be expedited. The visual management tools provide command centers real-time situational awareness at the facility, system, and individual unit level. To get away from the reactive firefighting, our machine learning analyzes and predicts 4 hours to 7 days ahead to provide advanced visibility into incoming demand. And when the system detects potential bottlenecks, we can then nudge key stakeholders to proactively collaborate to get ahead of them. As we look ahead, we believe this is just the beginning of our foundation for predictive capabilities. In addition to capacity intelligence I just described, there are additional use cases for the command center that we'll explore. These include optimizing discharge and barrier management across the system to give us real-time visibility into units where planned discharge targets are at risk, and they can collaborate in real time to identify additional AM discharges for the next day or catch delays for today's planned discharges. It will also help us be able to prioritize resources effectively, manage barriers across the enterprise. The next is optimizing patient placement across the system. One of our biggest challenges is how to load balance patients and manage capacity as a health system. And we want to make sure we optimize the access points for patients. In the future, the system will automatically detect the patient will be admitted, but inpatient units are predicted to be at capacity, or the patient can actually be at a lower acuity setting. So it can scan predicted inpatient census among nearby hospitals and suggest a transfer. This way, we're getting ahead of potential boarding. Qventus is automatically suggesting the transfer opportunity and prompting collaboration across the health system. Other opportunities that we're looking to address next include staffing. So SmartSquare is our enterprise staffing solution, and we see integration with that data as a way to see ahead of upcoming demand. And further out, we plan to have our command center be able to refer patients to other care models, such as a hospital at home, and have visibility into admissions and other factors. Overall, we are so much further ahead with this foundation of predictive capabilities, and we believe this will increasingly give us an advantage as a health system going forward. I really appreciate the opportunity to present to you. I'm going to pass it on to Monique, and we'll enter into a question and answer phase.
Thank you so much, and thanks very much, Debbie, Dr. Fangman, and certainly Mudit for sharing so many valuable insights on this important issue. So let's transition now to the Q&A portion of today's event. We've already received a number of questions, so let's launch into those. First, Debbie, I think this might be one for you. How did you convince your team to prioritize this initiative in the midst of the pandemic?
Actually, it wasn't me that convinced folks to prioritize it. We actually wanted to pursue the advanced analytic capabilities in 2019, just prior to the pandemic. And then when the pandemic had kind of put things on a back burner, but when Qventus brought forward their COVID planning tool, we saw that as a great opportunity to help us really have more insight into what was happening with that disease progression in our community. So we started leveraging the COVID-19 planning tool and also the predictive capabilities around managing the operative cases, that we saw a lot of advantages as we were navigating through the pandemic. So it just reinforced what our clinical leaders and our central patient logistics folks were asking for. So I didn't have to do a lot of convincing. There was a lot of interest organization-wide and just really driving throughput in our organization, and this was a tool that really seemed unique and different from what we had experienced in the past.
That's great. Dr. Fangman, anything to add to that?
Well, I was in on the initial view of this platform, and the thing that really struck me was, as an engineer, the focus on the constraint theory. I do think that it fits really perfectly with what we're doing and in throughput. We've been, as a hospitalist group, really focusing on throughput for a long period of time, with, inching forward with things, seeing patients sooner, working a little harder, but having the automation of some of these processes and the prediction of barriers is really key. And that, when I saw the methodology behind the Qventus, that's when I said that whether we use Qventus or another platform, eventually everybody's going to be building something like this to help, be proactive about inpatient throughput and be proactive about everything, having predictive analytics to really predict what you're doing and use it real time with your existing folks. So
great. Here's a question that just came in that I think is invaluable, and that was from one of our listeners. What do you think the biggest single biggest capability that needs to be in place before moving in this direction with these capabilities? Debbie, Dr. Fangman, any one thing that you can cite to that listener?
Well, I think the establishment of that central patient logistics center, that operational and that, single governance process is really important, and to have that leadership structure in place really needs to be there. And then you've got to have the operational buy-in in order to drive the actions necessary there. I think the other thing that is really important is the establishment of that standardized multidisciplinary rounding process. So there's a lot of change management that's required with being successful here. And so you have to really focus on that operational structure, the governance, and then the process and defining that standard process. I'll let Tony chime in. He may have other inputs.
Yeah, it's sometimes difficult, when you are at a place with the resources you need, St. Luke's being one of them, in my opinion. Having a champion, a physician champion, a nursing champion, you can't do anything in medicine, it seems, without having champions at those levels. So I do think having a medical staff open to looking at this, engaging them early so that they understand what we're doing and not that just we're doing another thing. I think early communication, engaging the physician leadership and the nursing leadership, and having them on the same page so they know what we're doing and why we're doing it is key. Maybe your question was more about, what do you have to have in place? We do have, a large multi-specialty physician group. We have, one EMR through most of our hospitals. So those things are definitely helpful.
Yeah, in fact, to add something that I think Dr. Fangman and Debbie are absolutely spot on. I think the foundational pieces of leadership, governance, and helping sort of people understand the why is super critical. And I think back to the same point for us, that's why it's always been critical to provide the platform, but realize that those critical components need to be in place and bring change management and expert services and best practices along. And having excellent partners like them on the other side is what really the critical capability is really needed to let those pieces of capability shine and deliver the ROI they need to.
Thank you so much for weighing in on that. Invaluable insights. So, Debbie, another question for you. Why did you choose to partner versus building the capabilities within Epic?
Well, within our organization, we do not have the data science skill set to try to develop this type of advanced analytics. So we do have to partner with other organizations to add this kind of capability, and that's the primary reason. We don't typically build products at St. Luke's. We usually, partner with a vendor and implement delivered solutions. I will say that we have, in the past, always been kind of a fast follower and always wanted to wait for something to be truly baked before we implemented it, but we've really increased our risk threshold and been really looking at solutions that are unique and different and that might differentiate our capabilities. So have been more willing to, adopt new capabilities that are coming into the market.
That's great. Another question that came in, and Mudit, I'll direct it your way, is a question about whether or not the system would actually predict the best next level of care based on the analytics. Is that something that the Qventus solution can incorporate?
Yeah, no, thanks for that question. Yes, and actually not just, think of it as not just a point-in-time prediction, but an evolving way of supporting the care team's decision-making around that. So right in the beginning, at the earliest stages, we are predicting right away if a patient will go home or they'll need post-acute care. Where there isn't a point of view yet, it's auto-populating that. And then continually, as the patient's condition is evolving, as they're on IV meds or not on IV meds, or taking oral diet versus taking liquid diet, we are supporting that level of care determination as well. So, for example, if currently the patient's on path for a SNF and we agree, we'll give that feedback. If currently the patient's on path for SNF, but seems like a patient who may end up being fine going home, then we also prompt that discussion for the care team. So there's multiple ways of both giving the determination, but also prompting the discussion and supporting the decision as it's being made, that the system does all of those levels of predictions along the stay of the patient.
I will add that the accuracy of those predictions gets better as you use the system and because it's continuously learning. So as inputs are being received, if it says, hey, we predict the patient should go home on this day, and you adjust it based on clinical decision making, it is constantly learning and taking those inputs to generate that next prediction it's making. So the machine learning capability is really very helpful, I think, and we have the dashboarding and the capabilities to monitor the accuracy of the predictions with the Qventus tool, and I think that's an important factor to know about.
That's
That's a really good point, Debbie, because I think oftentimes the word prediction is used for even a static prediction, i.e. you just create a set of rules to use it, but it's very important, we found, to have predictions learning ongoing and being localized. So they can actually understand your environment, your post-acute capacity, your processes, your population, as well as understand that as it evolves over time as well.
Fabulous. Another question that came in, I'll direct it to Debbie. How does this work with Qventus kind of fold into your overall digital strategy at St. Luke's?
So our digital strategy focuses on our digital front door, care transformation and optimization of processes. It focuses on advanced analytics and developing new capabilities from an analytics perspective to drive us to more of a real-time operation and process automation. So the Qventus tool really hits on several of those pillars of our digital strategy. So it's helping us with developing the automation, it's introducing those advanced analytic capabilities, and it's really helping us with supporting some of our care transformation initiatives. So we see it really aligning well with what we're trying to accomplish from an overall digital health perspective.
Right. And Mudit, is that consistent? Is that approach consistent with other Qventus client organizations?
Yeah, I think we see in many ways, I think exactly as Debbie was saying, these goals of providing access to patients, throughput, affordability, and consistency are pretty core to the pillars we see across customers. In many ways, the pandemic exposed the tax that care operations place on our staff, on our patients, on our capacity to serve them. And I think health systems, we find, are consistently looking for ways to improve that capacity creation so that they can have access, improve reliability, reduce the burden. And therefore, a core part of the strategy for many is to find these areas, the high ROI areas of care operations automation, and we partner with health systems in giving them a high degree of confidence in achieving that ROI by both bringing the automation platform to best practices and change management services to achieve that. So I think that's actually fairly consistent right now, and I think it's been a significant increase in that focus, especially over the last 12 to 18 months.
Great, thanks. And Dr. Fangman, I can direct this next question to you. Feeding on perhaps some of your earlier comments, how did you approach the change management within St. Luke's to ensure success of this program?
So, as the hospitalist and director, this is, the inpatient side of changing change management. We're talking about case managers, physicians, nurse practitioners. The key for us was, for me, in the past, was to get a champion. So we engaged our local leaders at each location. Specifically, we started at St. Luke's East with our director there, Dr. Jessica Lee, the CNO there, and the leadership from the nursing staff. So there was lots of early meetings with what's going to happen, why it's going to happen, how it's going to happen, and showing them what is the benefit for them. So the slide that we showed earlier with the decrease in number of volt messages, that's one of the biggest things for physicians and nurses and frontline staff is you get a volt message in the middle of seeing a patient, and when you're getting out of the patient room, it interrupts your flow. It really disrupts a lot of things and slows you down. So showing that there's a decreased number of interruptions in your day and showing them that early on in regular communication. So Jessica Lee has a healthy technology, as most of us do, and early on didn't understand some of the things that were going on, but with the meetings and with engagement, why we're doing that, she's now become a champion of it. And so I'd say that's probably my biggest thing, is finding a champion, communicating early and often, and engaging them in the process. The ancillary services really didn't require a lot of change management that I'm aware of, Debbie. I mean, maybe you have more insight than I do, but it seemed that they liked the fact that their work cues were more directed at what needs to be seen first, because I'm sure they got pulled in many different directions when it was first in, first out. Why aren't you seeing my patient first? But now they're, prioritizing who sees the physical therapist, which patient the physical therapist sees first. So I think that they like that prioritization. Debbie, you might.
Yeah, I think, everyone likes, not having to kind of think through, well, what am I going to do? Which ones am I going to prioritize? And kind of the noise is what drives the work. And so now they have, a prioritized list that they can work from. It does decrease the constant contact and saying, hey, will you take care of this? Will you take care of this? And that's always perceived well, I think, by anyone, not being interrupted or constantly pulled in multiple directions. We did do a process redesign effort around multidisciplinary rounds as part of our implementation. And we brought all of the key stakeholders together, and we redesigned that process, leveraging what we understood to be best practice, and implemented that effort. And that meant standardizing the process in all of our units in those hospitals, and actually executing that multidisciplinary rounding process on a daily basis. That helps to get everyone on the same page, everyone's coordinated. There's an ability to review your ICU patients to understand who's ready to step down, so you can, get them moved out of those ICUs when it's appropriate to do so. So I really think, that required a lot of change management, just standardizing that process and then implementing that across the system within those hospitals. So that was another kind of change effort that we had to implement.
Well, great. That's tremendous insight. So that concludes the time we have available for today's session. Shortly, all attendees will receive an email with a link to the webinar session replay and the presentation. We welcome your sharing that with others in your organization. So thank you so much for making the time to participate in today's webinar, and certainly a very sincere thank you to our sponsor, Cuventus, and to our very informative speakers, Deborah Gash, Dr. Anthony Fangman, and Mudit. That concludes today's program. Have a wonderful afternoon, and please stay safe.
Thank you, ladies and gentlemen. This concludes today's event. You may now log off